hemorrhage, again I'm telling we should not confuse that with hemorrhagic stroke. Intracerebral hemorrhage is when you have an intracerebral bleed. Okay, intracerebral bleed. When you say hemorrhagic stroke, it encompasses intracerebral bleed as well as it is a hemorrhagic transformation of an ischemic stroke. Okay, so hemorrhagic stroke, I don't say hemorrhagic stroke, others will make mistakes. Say IC bleed and stroke with hemorrhagic transformation. Say it like that. So IC bleed or stroke with hemorrhagic transformation. When you say hemorrhagic stroke, it also means IC hemorrhage, it also means an infarct that has been converted to a hemorrhage. Okay, for the purpose of now, the talk is completely based on what is a spontaneous intracerebral bleed or a spontaneous intracerebral hemorrhage. Right? So this can occur in two types. It can occur because of large vessels bleeding or small vessels bleeding and others. So if someone asks you etiology, why this has occurred, there has to be three reasons for it. One, that there is a small vessel that has bled and caused an intracerebral bleed. Second would be it's a large vessel that has ruptured and caused an intracerebral bleed. And the third would be the fact that there has been other reasons why it has bled into the brain. So let's come to each one of them. So when you say small vessel bleeds, these are characteristically the intra-hypertensive bleeds that you have. Intracerebral hypertensive bleeds are the small vessel bleeds. Okay, when the small vessels, how does that occur in hypertension? You are having a high blood pressure, you have lipohydrolysis of your vessels are getting worse and worse, endothelial rupture is occurring, then you bleed into the brain. Small vessel bleeds. Okay, small vessel bleeds are usually hypertensive bleeds. So characteristically these bleeds are present where? Where are they present?
Brainstem.
Where are they present? Basal ganglia. So they are present in the basal ganglia, thalamus and the pons. Classically, they'll be in the basal ganglia, thalamus and the pons. Classically. So when you have a patient who comes in, so what is the implications as a doctor for you? So once the patient comes in, you see an IC bleed in the basal ganglia region or you're seeing it in the pons, you're seeing the thalamus. The next step is this a chronic intracerebral hemorrhage? Right, and for that, for chronicity or hypertension, I need to figure out whether there is CKD, whether the kidneys are okay, whether there is hypertensive retinopathy, whether there is LV hypertrophy, whether there is a past history. You got the point? Past history, again, no, it is hypertension, that's why the hypertensive bleed probably. But corroborative evidence would be CKD, would be diabetic retinopathy, would be the heart being LV hypertrophy. You understand? So corroborative evidence will come from your background saying that this, because that's going to be a future target. Your future target would be getting that BP under control, ensuring that endocrine damage is not occurring. That is going to be a future target. So if you have a bleed of that nature, this is how your etiology are thinking. Clear? Clear on this? On microvascular bleeds. Now and the commonest region, you know where it is. So 80% of your bleeds, 80% of your bleeds are going to be these hypertensive hemorrhages. 80% of your bleeds are going to be these hypertensive hemorrhages. Okay, but you should be clear that this is hypertensive hemorrhage, nothing more. How do you recognize an hypertensive hemorrhage? Because it's a deep bleed. Okay, it's a deep bleed. Just now we said basal ganglia, we said thalamus, and we said pons. So on that figure that she put up the figure, you saw basal ganglia. That's why the figure is very important to understand where it is. So if it is in the cerebrum, it is not a hypertensive, unlikely that it is hypertensive bleed. For example, if this is the scene, if this is where it is, okay, so this is a very classical hypertensive bleed because it's in the basal ganglia, it's in the thalamus. It's a very classical hypertensive bleed. If the same thing would be somewhere here in this corner or somewhere down here, it is not a hypertensive bleed. Unlikely that it is hypertensive bleed. You understand? So why you must know that? Because there are further investigations that you need to do in such cases. You can't just rely on a CT scan. Are you understanding? You can't rely on a CT scan. So one of the commonest things you can do in such cases, if you really want to figure out whether this is hypertensive bleed, is to actually repeat an MRI. Okay, what happens with an MRI? What additional information you get for a hypertensive bleed? Anyone? Anything that you can get on an MRI?
GRE we can.
Correct. So on the SW1 and on the GRE, if you get microbleeds, okay, if you have microbleeds on the GRE and SW1, they pick up hemosiderin. So GRE and SW1, they pick up hemosiderin. So if I get a MRI and I see my GRE to be lighted up with hemosiderin or my SW1 lighted up, then it goes more in favor of it being hypertensive hemorrhage. It goes in favor of being hypertensive hemorrhage because these are microbleeds, microvascular diseases. Clear? The other category of patients is macrovascular diseases. Now what is macrovascular disease? You have an aneurysmal bleed. An aneurysmal bleed is a macrovascular bleed or a dural arteriovenous fistula that is bleed. It's a macrovascular bleed. You understand? You have cerebral venous sinus thrombosis causing a bleeding into the brain, the convexity of the brain. It's a macrovascular bleed. So classically these bleeds will be in those territories. They are not going to be like this. Where are they going to be? If it's an anterior communicating artery aneurysm, it will be in the anterior fissures, anterior intercommunicating fissures. Somewhere there it will be in the interhemispheric fissure. If it is a middle cerebral artery bleed, it is probably going to be near the sylvian fissure. That's why you need to know the fissure. If it's a posterior communicating artery, it's going to be somewhere near on the backside near the cerebellum or somewhere there. You understand? So it will be in classical territories. It will be in classical territories saying that this is where it is, right? Then the other, this is the macrovascular. Then you will have the others. In the others, what will come? Say tumor-induced bleed, vasculitis-induced bleedings. These are a very small sector, very small amount. So you will have to differentiate macro, micro, and this because the entire management would change. Right? Now, as a doctor in the intensive care unit, what am I worried about? If I have an IC bleed, what am I worried about? In the first 6 to 24 hours, what am I worried about? No? So, what kind of edema do you develop in these cases? You develop cytotoxic edema. You will develop cytotoxic edema. Why will you develop cytotoxic? What is the difference? As I told you, cytotoxic edema is when the cell dies. In ischemic stroke, what is happening? The cell is dying. In hemorrhage stroke, what does that mean? Cell is dying. When the cell is dying, you develop cytotoxic edema, which causes the cell to swell up because it takes calcium inside and it swells it up. Now, cytotoxic edema cannot respond to a steroid. That's why steroid is not a treatment for IC hemorrhage. Clear? So, this will take how much? This will take how much time? This will take time. As I told you, it is going to take time. So, edema will not develop immediately. What are you worried about in the first immediate time? Expansion of hematoma. That is what I am worried about. I am not worried about edema in my first 24 hours. I am worried about expansion of hematoma. So on an average, 1/3 of hematomas will expand by more than 33% in the first 6 hours. 3 is the number you must remember. 1/3 hematomas will expand by 33% in the first 6 hours. So 6 to 24 hours is the time that I have for hematoma expansion. This is what you must remember. Okay, so that is why if you want to do a CT scan, I want to do it at 6 hours and I want to do it at 24 hours. You understand? The reason you must understand the pathophysiology is because when do I repeat my scans? My scans are repeated at 6 hours and at 24 hours. You understand what I'm saying? So if you really want to understand if the patient suddenly goes down a little bit, I repeat a scan quickly. That's what Dr. Mahesh Chaudhary does know. If a person comes to hematoma, he says, वापस एक scan करो. 6 घंटे में स्कैन कर देते हो तो ऐसा लगता है कि क्यों कर रहे हैं हम 6 घंटे में कर दिस इज द रीजन बिकॉज द फर्स्ट थिंग इज हेमाटोमा एक्सपेंशन देन आफ्टर दैट इन 24 hours we have another expansion. That's why again he repeats a scan. You understand? So first 24 hours is completely based on hematoma expansion. So when does edema come? Yeah, after 3-4 days. I'm not really worried. In the first 24 to 48 hours, I'm hardly worried about edema. So in usual IC hemorrhages like this, up to 24 hours there's hematoma expansion. However, if there's an anticoagulant induced bleeding, that will take 48 hours. So if there's anticoagulant induced hematoma, that will take 48 hours for it to get off. Okay, though the action of the drug may be 24 hours, but these hematomas are known to expand up to 48 hours. So my hematoma expansion would be twofold. One, for a primary ICH without a dual non-oral anticoagulant, and one with the anticoagulant. If it's with an anticoagulant, 48 hours. So I must think this way. If my patient has had an anticoagulant-induced bleed, I want to repeat my scan again. That is exactly what we did with the patient who came with anticoagulant-induced bleed. We did with that same anticoagulant-induced bleed. At 48 hours, we repeated the scan. Clear on that? That's about oral anticoagulant bleeds. Clear till now? Okay, so edema settles when? Edema settles at anywhere between 3 days to 6 days. So that explains the duration of neuro observation, close neuro observation. So if you have a patient who is coming in with IC hemorrhage which is large in nature, I need to observe this patient for a period of around 6 days in the intensive care unit, because up to 6 days there will be hematoma induced edema which is cytotoxic in nature. Clear? Clear till now? Alright. Now, I am worried about hematoma expansion. Is there any way I can understand whether this patient is going to have hematoma expansion? Are there any signs that tell me that this hematoma is going to expand? Do you know of any signs?
Drop in GCS more than 3.
That's clinical. That is not indicating that hematoma is expanding. That is only telling you that the patient is deteriorating. That's just neurological worsening. How can you predict a hematoma expansion? How can you predict it? Which are the signs? So there are a couple of signs that tells you that the hematoma is going to expand. So the first sign that you need to know is called as the swirl sign. The swirl sign. So if you have a hematoma with different, now this entire hematoma is showing just one white. Okay, if there was one white, one small black, one white, the density is changing. If there is multiple densities, okay, it is also called a swirl sign. Okay, it's also called a swirl sign. If there is a single hole, single black inside, it is called as black hole sign. It's called as black hole sign, swirl sign. So swirl sign is generally indicated when there is contrast. If you do a contrast and the contrast extravasates into this, in a CT angiography. Okay, contrast extravasates into this. That is called as swirl sign. If you have two different densities, it is called as, I think, dense hypodense sign or something it's called. Okay, density different. Third is if there is a black hole sign, that is there's a brown, this color over here. Okay, this color over here. It is called as black hole sign, which indicates that you may have a hematoma expansion. The fourth is called as the island sign. What is island sign? When there are at least 3 separated hematomas, separated areas between the hematoma. Again hematoma आ गया. हेमाटोमा इधर एक सेपरेटेड आइलैंड है, इधर एक सेपरेट आइलैंड है of this normal tissue. It is called as island sign. So you have swirl sign, you have, I don't know what that dense and hyperdense was called, I don't remember that, but that's, you understood, if it's dense and hyperdense in that area, and then you have a black hole sign, and then you have the final island sign. When you have all these signs, these indicate that there is a chance of hematoma expansion. This is one of those fields in which I need to act quickly. Okay, clear on this? Another thing, characteristic of an oral anticoagulant bleed is the fact that you will have density hypo and hyper. You will have hyper and hypo. So you will have even a fluid inside the hematoma. You will get a fluid sign also, like a fluid marking. Okay, so you will have dense and hypodense and hyperdense, or anticoagulant induced bleed. Okay, clear on this? Clear? So that will explain to you your hematoma expansion. So when a patient of hematoma comes to you, the first thing that you should do as an intensive care doctor is to actually write down the ICH score. There are 2 types of scores. One is the ICH score and the other is ICH functional score, ICH FUNC score. 2 scores. So you should be always documenting the ICH score. Why? Not because JCI only has told us. JCI has anyways told us. If you wanted to be a stroke center, if you do not record the ICH score, you cannot be. That's one of the implications to do JCI. You have to have the ICH score on paper. What does the ICH score say? The ICH score gives you a severity of the particular bleeding, and there are 4 or 5 things that are there. If I remember clearly, one is the age. If the age is more than 80, the score becomes 1. It becomes higher. Okay. If the bleed is infratentorial, it becomes higher. If the bleed size is more than 30 ml, it becomes higher. Okay, if the GCS is low, it becomes higher. So these are the various categories of ICH score. Okay, but the ICH score you cannot look at the ICH score and tell the patient that functional improvement will not take place. Are you understanding? The ICH score is a language that you speak among yourself as medical doctors. Okay, you will say ICH score is 5, ICH score is 6 among our doctors. Not to the relative, saying that it is severe, he will not improve. It is not like that. Don't take it that ICH score will tell me about prognosis. It's not going to tell me about prognosis. It is just a common language that we all speak. For example, you have a patient that is coming in from the ambulance. Okay, that person has to call up and say ICH score is so much. So you know, okay, SI. It is also used for trial purposes. If the ICH score is so and so, what happens when you operate or you don't operate? So it gives you a common metric to dichotomize patients and put them into different baskets for a trial. You understand? It cannot be used for prognosis. You cannot do that, because you give a simple example. If a person is 79 year old, not 80, okay, and he has got a very small hematoma in the cerebellum, which is infratentorial, okay, and his GCS is low because he's had a couple of drinks, this patient is going to improve. But if you put in the ICH score, it is 100% mortality. Understanding? If it's a 79-year-old male who just had a couple of drinks, fallen down, his GCS is low, he comes to you, and you find a cerebellar hematoma, which is the best prognosis in IC hemorrhage. You understand? I get a cerebral hematoma evacuation done. Patient will be GCS 15 by 15 in the next 24 to 48 hours.
So we have patient on bed number 8.
Correct.
Recently, without operation.
Correct. Correct. I see. So
She-
if
she
that
was done
patient,
once,
if you put that patient in the ICH score, so let's look at that. You got an MD calc on you? Open up MD calc and put ICH score. Let's put her on this. Okay. Just put MD calc. Let's do it one by one. What is the first score that we need to understand that? What is the number?
GCS.
GCS. So let's put the GCS there. MD calc open here.
Yes, ma'am.
Okay. What is the GCS?
If it's 3 to 4 plus 2, if it is 5 to 12
3.
plus 1.
So 3 to 4. Hers were 4 only. 3 to 4. So let's put it as plus 2. Then age. Age was 72. 72 na?
Around 70.
Then-
70. So
No,
0. Then
ICH volume.
ICH volume. His was more than 30 ml.
So
Huh?
it is yes.
Yes. So how much is it? Plus?
Plus one.
Plus 1. Then
IVH.
intraventricular hematoma. She had.
Ah.
Intraventricular hemorrhage she had. So
Plus 1.
plus 1. And then
Infratentorial.
infratentorial. It was plus 1 again. So how much does this come? 2, 3, 4, 5. Mortality is 100%.
100%.
Mortality 100%. Is she dead? In fact, she's conscious, obeying about eating food now.
Yeah.
You understand? Mortality is 100% as per the score. 5 again, no? So it will be 100%. Okay, you have a 100% mortality in the score. This doesn't show if I were to use the ICH score and then tell the relative, ये तो 100% मरने वाली है. I'm completely wrong. I'm completely wrong. You are understanding? Clear classical example that says this. However, there is another score that will actually tell you functional. It is called ICH function score. ICH FUNC score. Okay, that can be utilized to a certain extent, but still it is, you should also take that also with a pinch of salt. ICH function, ICH FUNC score. Okay, in that if you put it, let us see what happens. Let's put it, what the ICH function score says?
ICH volume.
Volume.
Plus 2, 30 to 60.
Okay.
Then age 70 to 79 plus 1.
Okay.
ICH location infratentorial.
क्या? 0. हाँ.
GCS score less than 8. 0. Pre-ICH cognitive impairment.
Normal. हाँ. So she was normal. So कितना है?
No, plus
उसमें?
1.
Plus 1. So what is the score now saying?
4 points.
Which means
0% probability.
of.
Functional independence at 90.
So it is saying at 90 days functional independence नहीं होगा. But it doesn't talk about mortality. Are you understanding? This is called ICH functional score. So you can talk to them saying that at 90 days probably patient may not be completely functionally active, but over a period of time may get active. So you can use this in place of ICH score if you want to counsel relatives. You understanding? Don't put it on paper. Mortality इतना ही है, ऐसे नहीं डालना है. But you can use this as a clinician to actually explain to relatives. Okay, maybe at 90 days patient may not functionally be independent, but maybe after a couple of days he will get better. If you put the other score and try to use it, it is very wrong. If you put the other ICH score, you're completely out of everything, isn't it? If you look at the ICH score, clear? Alright. So we talked about what the ICH primary ICH score, this intracerebral hematoma, how does it form, macrovascular, others, and then we came to understand what is the in which patients you will have the ICH to increase and hemorrhage expansion. We understood what is edema that comes in, when does edema comes in. Fourth, we understood how the ICH score can be interpreted or ICH functional score can be interpreted in these cases. Now we come to what is the management. So what would be the management? So which patients will require CT angiography? We just talked in the middle of CT angiography. Now first day as part we did a CT. Which of those patients will require CT angiography? Do you require to do CT angiography and for what? Why do you need to do CT angiography in an IC bleed? Do you need to do it?
To see aneurysm.
Yeah, to see aneurysm, right? An IC hemorrhage can occur because of an aneurysm. So which are those patients that will require the CT angiography?
So
Non-hypertensive.
So non-hypotensive. Correct, non-hypotensive. So if you have a patient who is aged less than 45 years old and develops an IC hemorrhage, this patient, whatever happens, even if he is hypertensive or not hypertensive, requires a CT angiography.
Even a patient is supposed chronically hypertensive also.
Still less than 45 years old, to cause lipohyalinosis, to cause all those things, it takes a while. It takes a while to cause the artery to get spoiled and all these things. It will take us. That's why if it occurs within 45 years, irrespective of what the patient is, whatever disease it is, you go into a CT angiography. It's important to get that done. Second, If a patient is between 25 and 75 and not hypertensive. If the patient is between 25 and 75 and not hypertensive. So those are other patients that will require CT angio. Okay. And the third is those who are above 75 and in the lobar location of bleed. Above the age of 75 it is lobar location. Okay. Above the age of 75 it's a hypertensive bleed. Where are you expecting it to be? In the basal ganglia, in the thalamus, in the pons. But if it's above 75 and your lobar location of bleed, you are looking at something else. You need to figure out what it is. So that is one place where you will use a CD angiography. It is a class 2A recommendation for any patient for that matter. Tomorrow if you do a CT angiography for all IC bleeds, it's a class 2A recommendation, not class 1. Class 1 is CT scan. Class 2A is CT plus CT angiography. You won't be wrong. You will never be wrong if you do a CT angiography. You will never be wrong because class 2A recommendation is hey, whatever happens. But these are those patients in which you have to do it. Okay, you have to do a CT angiography. Clear? There are certain cases where you do a CT venography. Which are those cases? Which are those cases? So when you are suspecting that the hemorrhage is in the convexity, if the hemorrhage is in the convexity, which is this patient? You have a patient on bed number 2, right? Cerebral venous sinus thrombosis. Cerebral venous sinus thrombosis. What is cerebral venous sinus thrombosis? Convexity hemorrhages. When there is convexity hemorrhages, when there is extreme Sylvian fissure hemorrhages, which is coming from the transverse sinus or from the straight sinus or the sagittal sinus, you have convexity hemorrhages. Those, or you have something called as swirl hemorrhage, or kind of wavy hemorrhage. Okay, anywhere. In those cases, you will require to do a venography because that is a hematoma that is coming from cerebral venous sinus thrombosis. You understand? So in those cases, you will require a CT venography or an MR venography. Any of the two. Somewhere a CT venography or an MR venography, which will give us an idea what is happening over here. Because the treatment is completely different. That's also part of hematoma. But that's why you need to understand where it is coming from. Where is it on the CT scan? Is it in the basal ganglia? Is it in the convexity? Is it in the cistern? Or is it is it in the Sylvian fissures or interhemispheric fissure where you can have these kind of subarachnoid hemorrhages indicating aneurysmal bleeds? CT angiography, CT venography. Is there a role of an MRI? Yes, there is. If you have an abnormal location of a bleed and you want to figure out what is happening over there, whether it's a tumor, it will be seen much better when you have an MRI. It will be seen much better when you have an MRI. In that case, the only problem is gadolinium. If you want to give contrast, it interferes with the hematoma. Okay, so you don't want to do it immediately. You want to do it after some time. Because in MRI, what happens is, in some time, the blood will change color. Okay, so you don't do it on day 1. अगर तुम MRI करना है 2 दिन की बात कर लो. Okay, because then when you give gadolinium, you don't want to do MR in patients on hematomas, immediate hematomas. उसमें कोई मतलब ही नहीं होगा because when you give contrast, it will look the same. You don't know what is where. That is why you wait for 2 days. When the blood gets isodense, you will probably use. Otherwise, it's hyperdense. Okay, on an MRI, blood will become hyperdense. So you want to make it isodense, and then you will probably look at it. The hyper means more item. Iso means equal to brain, and hypo means lesser than brain. Okay? So when it becomes iso-intense, that is when you give gadolinium to understand whether there is vasculitis, TB vasculitis. That can also give convexity hematomas. Okay, TB vasculitis, or you say there is a cerebral venous sinus thrombosis, or you have a tumor. All these things will require contrast. Venous sinus will not require. This will require contrast. So when you're giving this contrast, it has to be done in very correct technique. You can't just do it the day that the patient is coming. Clear? So what is the treatment now? You understood the bleed. What is the treatment? Now say let's take it primary intracerebral hemorrhage of hypertensive origin. Okay, because SCH will have a completely different, cerebral venous sinus is completely different. We are looking at primary intracerebral hemorrhage. What will be the treatment?
Blood pressure control is.
So what is the pressure required to keep?
If their systolic is more than 220, then we have to control the.
That is stroke, ischemic stroke. This is ischemic. Don't confuse. Ischemic stroke mein, if the blood pressure is more than 220, I need to control it. If I am not thrombolizing, if I am thrombolizing, let's keep it less than 180. If I want to do thrombolysis, it has to be less than 185. Clear.
160 is the target. Systolic BP is 140 to 160 target.
So the answer is I will never get it less than 130.
Yes.
I will never get it less than 130. That is the first answer. The first answer is I will not get it less than 130. What will be my recommended blood pressure? Somewhere between 140 to 160. I don't know what it is. Whether it is 150, whether it is 160, whether it is 140, I don't know. Okay, it's between 140 and 160, and that's what the trial told. She's mentioned two trials, the interact and the attached trial. The interact and the attached trials were two major trials that was done to understand what could be the lower range of blood pressure. So they brought the blood pressure to up to 140, 160, there was no problem, 150, there was no problem. But when they compared it to 110, the overall outcomes were not okay. So they had three groups, 110, 140 and above 160. You know, so the ones when they brought it to 110, they found out that these patients did not do well. That's why what is the blood pressure that we have? Above 110. And when the interact trial came first, the attach was the first, interact was the second. 130 was said to be the limit after which beyond which there is a problem. So we will not get it to less than 130. We will keep it between 140 and 160. This is what we will do. It also depends on what you're doing. So we have come to here till now. Blood pressure. Okay. What is the next thing you would like to do in these cases? Take the blood pressure target. Okay. Second,
cerebral edema.
cerebral edema prevention. So you would like to use one of these places where you're going to use any of the anti-edema measures, which includes mannitol, which is not grade 1 recommendation, but you may want to use that mannitol as well as hypodermic saline in such cases may use in ICF. The only place where you can use hypodermic saline or mannitol or anti-edema measures. Then more important than that, control of pain. That is more important. Okay, if you control pain and you give sedation to these patients, they do much better than otherwise. Okay, if you give control their pain, they have headache, they can't tell you headache. So you control the pain, things will get much better. Okay, and as I told you last time, what is the blood pressure you will use to get this blood pressure down? You will use medicines, right? Which are medicines? As I told you, in order levodopa or levodopa or
clevidipine.
esmolol. So how do you give esmolol? 25 milligram bolus followed by 3 to 4 milligram per minute. Simple. This is what you give for esmolol. Okay? Esmolol, labetalol, if you want to give 10, 20, 40, 60, 10, 20, 40, 80, 300 milligrams. Okay? This is what you'll probably give as labetalol. If you can't give labetalol, put on NTG. Labetalol is not a great drug for antihypertensive because of the fact that it is beta. It's not alpha. The problem here is alpha. So that's why the drug of choice remains clevidipine, nicardipine. We don't have it, so we can probably give a combination. Clear? Alpha. Clear on this? So, but of course, if you want when to convert into oral is after 24 hours. So first 24 hours don't do anything. After 24 hours, you may consider converting into oral medicines. And in those oral medicines, the drugs that you would use, the first drug of choice would be Dicardia. Okay, the next drug of choice would be prazosin because it's alpha. Okay, and then you would get metoprolol in place. And in the metoprolol, the better drug to give is metoprolol tartrate than succinate. Why? Because it's faster acting and faster coming off. So you might give it even 4 times in a day. You understand? Succinate will have to be given twice in a day or once in a day. Clear? Metoprolol. Clear?
Control of treatment of ICP. First is BP control, then anti-edema
measures, sedation and pain management,
fever control,
and then
temperature.
Fever, DVT prophylaxis. If fever, patient should not have fever. Patient should not have fever. Whatever happens, आना ही नहीं चाहिए. मतलब ऐसा नहीं कि हम 101 पे आके उसको पैरासीटामोल देते. वो 97, 98.6 पहुंचा, you start antipyretic. You have to start that. And the last is about surgery. Okay, so what is clear about surgery is that it doesn't alter outcomes, especially if the GCS is low. In fact, it harms. If the GCS is less than 9 and it's a large cerebral bleed, it's not helpful at all. Okay, the only category where it actually improves outcomes in a very big way is when there is cerebellar hematomas. Okay, cerebellar hematomas. So if cerebellar hematoma is more than 15 ml, that is where the surgical things will come inside. For example, if you have an intraventricular bleed or a fourth ventricle compression, you may put an external ventricular drain to remove the hydrocephalus. That will improve the patient very well. Okay, if you have a patient who's having 15 ml plus in the cerebellar hemisphere and neurologically going down, you can do a decompressive craniotomy in the posterior fossa, patient will improve. So these are the few places where patient will improve if you do a decompression craniotomy. Clear? Clear? I think that's about IC Haemorrhage. Okay.